Bismillahirrahmanirrahim. Assalamu alaikum. First of all, I would like to thank you, the organizing team at PUMS, and also the faculty, especially Dr. Abdulaziz Sahto. I'm Dr. Syed Kashif Hussain Kazmi, consultant endocrinologist and obesity specialist. It is an honor to speak here in Nawabshah, the city where I was born, and I started my education from a poor school. I have pasted a picture of a poor school. I am emotionally attached to this school. After graduating from Liaquat Medical College, Jamshoro, I completed my specialist training in endocrine and diabetes, including advanced training at Cambridge University Hospital. I have also put a picture over here. Today, I'm privileged to share insight on the medical management of obesity. While time is limited, I will be discussing few important points. I will be also discussing about pharmacological agent semaglutide and tirzepatide. First, we will discuss the statistics. The global 2025 obesity atlas indicates we are facing an accelerating crisis that is rapidly increasing. By 2030, 3 billion adults, or 50% of the global population, will have high BMI, including 1.1 billion with obesity and zero point 0.4 billion with the severe obesity. The epidemic already drives 1.6 million premature death and 44.3 million years of ill health annually. And the lifetime risks now exceed 50% in 147 countries. It's quite alarming. And unfortunately, we are not prepared to deal with this epidemic, and we are not prepared. Only 13 countries in the world fully ready, and zero nation having implemented uh, prevention policies. This slide highlights the rapidly worsening obesity burden in Pakistan. A World Obesity Atlas data shows that by 2025, an estimated 61% of adults will have a high BMI, with number projected to surpass 106 million by 2030. This prevalence is already driving major morbidity. Nearly 780,000 person years of non-communicable disease ill health in 2021 only, fueling conditions like type 2 diabetes, ischemic heart disease, stroke. The policy table underscores a critical gap: the absence of national guideline for high BMI management. These trends make clear the urgent need for evidence-based pharmacotherapy and earlier, more targeted intervention. So this slide shows the evolving definition of obesity, shifting from BMI-centric model to a more clinical, meaningful framework focused on health outcome. Traditionally, obesity was defined as a BMI of more than 30 kilograms per meter square, a metric that fails to account for body composition, fat distribution, and individual health context. The newer definition is recognizing obesity as a chronic heterogeneous metabolic condition driven by adipose tissue dysfunction and its systemic consequences. Diagnosis now involves assessing excess adiposity alongside metabolic, anatomical, and psychological impact. So we go to the next slide now. So, fellow practitioners, stop using the standard Western BMI charts. They are misleading for our population. In Pakistan, we must use the Asian specific lower cutoffs for treatment. Our patients face severe metabolic risks like diabetes and heart disease at lower weights than Westerners. If you wait for BMI of 30 to diagnose obesity, you are intervening too late. For us, overweight begins at 23 of BMI and obesity at 27.5. Adopt these stricter ranges today to ensure we catch high risk patients before it's too late. What is the importance of weight loss? Why people should lose weight? This slide shows a dose response relationship. As weight loss increases, clinical benefits expand from symptoms management to disease remission. and mortality reduction. We start with a modest weight loss, achieving just 5 to 10% weight loss yield immediate metabolic improvement, including better blood pressure, lipids, and liver health, as well as sleep apnea relief. 10% weight loss, pushing beyond 10% shifts the focus to prevention. We see reduction risk for kidney disease and cardiovascular disease, and notably the possibility of type 2 diabetes remission. At the highest tier, exceeding 15% weight loss provides profound protection, reduced cancer risk, improved cardiovascular health and heart failure outcomes, and overall reduced mortality. So the key takeaway over here is that simply put, greater weight loss unlocks broader and deeper health gains. Effective long-term weight management is based on four pillars of treatment, including nutrition, activity, behavior, and pharmacotherapy. Unfortunately, I have time limitation, so I will be just discussing about pharmacotherapy. Before going into the details, we should look into the history of GLP-1. In the early 1990s, a researcher named Dr. Adjourning was studying the Gila monster, which is a lizard. He was fascinated by the lizard's ability to eat huge meals, up to 30% of its body weight, only a few times a year, and maintain stable blood sugar without crashing or hypoglycemia. So Dr. Johning discovered exenidin 4 in its saliva, a GLP-1 like molecule naturally resistant to DPP4 or dipeptidyl peptidase enzyme 4, giving it far greater stability than human GLP-1. This breakthrough led to exenatide in 2005, the first GLP-1 receptor agonist. From there, innovation accelerated, liraglutide introduced for daily dosing, and then came to semaglutide and tirzepatide. I will focus on two medications currently available in the market, semaglutide and tirzepatide. Semaglutide is GLP-1 receptor agonist, uh, and it is notably shares 94% similarities with the native GLP-1, but features an extended half-life of roughly 165 hours. Upon activation, it acts on hypothalamus to suppress appetite and on the stomach to slow gastric emptying. Additionally, it targets the pancreas to enhance insulin secretion in a glucose-dependent manner. These all combined effects cause weight loss. So, who should get this medication? In the UK, we follow NICE guidelines, which are well-structured guidelines. So, this slide shows NICE requirements for prescribing semaglutide. So, it is only for a specialist weight management service and always paired with the diet and exercise. So it's a lifestyle modification is required with this medication. Standard eligibility is a BMI of 35 with the relevant comorbidities, with the threshold reduced by 2.5 BMI points for South Asian. We also use this medication in patients with the BMI of 30 or more with comorbidities. So this medication is for 2 years as per NICE guidelines, and we are almost stopping the medication in case if patient is not achieving 5% weight loss within the first 6 months of the treatment. The reason behind these strict guidelines are because NHS is a free service to all. Therefore, it is all cost-effective driven guidelines. Before the initiation or starting semaglutide, patient must be screened for contraindication. The absolute contraindications are medullary thyroid cancer, MEN2, or multiple endocrine neoplasia due to the risk of C-cell hyperplasia or cancer. Use caution in anyone with a prior pancreatitis or significant GI disease like inflammatory bowel disease. We should inform the patient about worsening of IBD, or avoid giving them GLP-1 agonists with active inflammatory bowel disease. Ensure patients are counseled for symptoms, including milder symptoms and serious symptoms like of pancreatitis, gallbladder disease. Side effects are mostly GI related. The most commonest side effect is nausea. Patients should be counseled for these milder side effects. Or we can prescribe antiemetics for these patients who are getting these side effects. I will also highlight that these medication can interfere the absorption of other medication, including, for example, warfarin or novel newer anticoagulant agents. So there is a risk of either bleeding or clotting in these patients. So how we start the medication? Always remember, start low and go slow, typically with the 4-week dose escalation schedule. So we start with the 0.25 milligram initially per week, and then we go up every 4 weeks to the maximum dose of 2.4 milligram. But we must titrate up gradually. This slow titration is essential because it allows the patient's body to adjust to the GI side effects, which are common. Skipping steps or rapid escalation significantly increases the risk of severe side effects. Now we will discuss about the clinical significance or clinical evidence behind semaglutide. So there were a series of trials were done from step 1 through step 8 trial because a single study cannot answer all the important clinical questions. Step 1 trial evaluated 2.4 milligram in adults with obesity without diabetes. It produced unprecedented results for a non-surgical therapy with nearly 15% um, weight loss over 68 weeks versus 2.4% with placebo. Step 2 trial shows that semaglutide remains highly effective, and with the 2.4 milligram of semaglutide, patients lose 9.6% of weight. In step 3 trial, semaglutide with the intensive behavioral therapy led to 16% weight loss versus 5.7% therapy alone. In step 4, after initial loss, stopping semaglutide caused two-third weight regain, while continuing treatment maintained or improved result, reinforcing obesity as a chronic relapsing disease requiring long-term therapy. In the step 5 trial, semaglutide maintained 15% weight loss over 104 weeks, confirming durable 2 years efficacy. The step-up trial is quite interesting. 7.2 milligram dose produced 21% mean weight loss, with one-third losing more than 25%, showing a strong dose responsive approaching surgical outcomes. Together, the data reinforce obesity as a chronic disease and requiring sustained treatment. Step HFpEF showed a clear functional gain. Patients had improved quality of life and improved 6 minutes walk distance up to 21 meter. And also, SLEX demonstrated a 20% reduction in major cardiovascular events in patients with obesity and established cardiovascular disease. Now we discuss more potent tirzepatide, which works by activating both the GIP and GLP-1 receptor. GIP is glucose insulinotropic polypeptide receptor, creating a stronger metabolic effect in comparison to GLP-1 alone. GLP-1, as we discussed before, slows the gastric emptying, boosts insulin release, and increase satiety, while GIP adds further insulin support and may directly influence fat tissue and energy use. Together, they produce greater glucose control and more substantial weight loss. Again, use is limited to patients with the BMI more than 35 plus comorbidity like diabetes, hypertension, or sleep apnea with threshold 2.5 BMI points, lower for higher risk minority ethnic groups. It must be given within a structured diet and exercise program with a 6 month review. If patient doesn't lose 5% of their weight within the first 6 months of the treatment, then we stop the treatment. Again, before starting tirzepatide, screen for key contraindication as we did with the GLP-1 agonist alone or semaglutide. We should rule out contraindication and we should counsel the patient regarding pancreatitis and gallbladder disease. Uh, these risks must be balanced carefully for each patient, setting the stage for an important malpractice alert in this area. Tirzepatide uses stepwise titration, similar to semaglutide, starting at 2.5 milligram and increasing every 4 weeks to manage GI side effects. The maintenance dose is 10 to 15 milligram, with 15 milligram giving the greatest weight loss effect. It's once weekly subcutaneous injection and adherence to the titration schedule is essential to reduce adverse event. What is the clinical evidence behind tirzepatide? There were trials done, Surmount 1, which showed exceptional efficacy in non-diabetic adults, 20.9% mean weight loss on 15 milligram, 96.3% achieving greater than 5% weight loss, and over one third losing more than 25% of weight. Approaching surgical outcome, long-term data showed a 94% reduction in progression to diabetes, reflecting the power of dual agonism. Next, discuss Surmount 2 trial, which showed strong efficacy in type 2 diabetes, around 15.7% mean weight loss on 15 milligram versus 3.2 with placebo, with over half achieving more than 15% weight loss, nearly half reaching normoglycemic. These results confirm potent dual effect on weight and glucose control. So Surmount 3 showed that after a 12-week lifestyle lead-in producing 6.9% weight loss. In comparison, placebo patient regained 2.5%, ending with only 4.4% net loss. In contrast, with tirzepatide produced an additional 21% weight reduction for a total loss of 26%. The trial makes it clear that lifestyle alone hits a ceiling and pharmacotherapy is needed to overcome metabolic adaptation. Surmount 4 trial showed that after 20.9% initial weight loss, patient who stayed on tirzepatide reached 25% total weight loss, while those switched to placebo regained 14% of weight. Only 16.6 of placebo patients maintained more than 80% of their weight loss versus 90% who continued on treatment, highlighting obesity, chronic relapsing nature, and the need for ongoing therapy. The Summit trial showed that in HFpEF with obesity, tirzepatide cut worsening heart failure events or CV or cardiovascular death by 38%, improved quality of life, and increased 6-minute walk distance. And the trial demonstrated broad benefit beyond weight loss, improving both cardiovascular outcome and functional status. In summary, GLP-1 agonists mark a major shift in care, acting far beyond glucose control by reducing inflammation and oxidative stress and supporting mitochondrial function. They deliver upstream cellular benefit that translate into multi-organ protection, cardiovascular, renal, hepatic, and potentially neurological protection. Their broad pleiotropic effects position GLP-1 receptor agonists as foundational therapies for comprehensive cardiometabolic health rather than solely diabetes treatment. Now we discuss the surge in off-label and non-specialist prescribing has created real malpractice risk. I have been informed that in Pakistan there are dermatologists, dentists, and even non-medical persons are prescribing this medication, which is quite dangerous. These medications are good, but has a lot of side effects, and if you don't know the indication contraindication, there is a risk of like severe side effect, even death. So we have to be careful in prescription. The take home message is that we must reframe obesity as a chronic treatable condition, but it's a relapsing condition, not a lifestyle failure. These new medications are powerful tools, but they are not magic bullets. They must be integrated into a comprehensive multidisciplinary treatment plan. Our goal is to move beyond simply treating weight to treating the underlying metabolic dysfunction and improving overall health outcomes. This is a rapidly evolving field, and staying current on the data and guidelines is not just best practice, it is our ethical obligation to our patients. Thank you for your time.